You are listening to Walking Home from the ICU. We will be exploring how to save and preserve lives in the ICU. All opinions and views shared are unaffiliated with any organization. Brandy, thank you so much for being willing to talk about this with us. I'm really excited. So, as I've talked to nurses online about the fact that we don't put our patients in comas, I've been told that I was inhumane, unethical, cruel. So I'm really excited for an actual nurse to talk about what it's actually like in practice to take care of patients that are awake and even walking on the ventilator. So tell us, what is that like for you?
So my passion comes from a personal experience. I had a couple of uncles that were sedated, both of them for roughly a month. They were sedated, paralyzed during that time, off and on, and they survived. But both of them have long-term deficit, cognitive, post-traumatic stress from that experience. One has told me that his experiences while being sedated, although he realizes that they are unreal, he really feels like that was something real that was happening to him. And the times that he was awake on the ventilator, it was that the times he was sedated are worse than the times that he was awake, just because he could participate and be involved in and he knew what was going on rather than just being in this state of, being sedated and not knowing what's going on and being fearful. So that's where my passion comes from, to take care of patients awake on the ventilator, keep them interactive in their care. A lot of nurses worry that it's more work when your patients aren't sedated, but I find that it's actually less work because your patients will turn themselves. They'll reposition themselves in the chair. They're up watching TV. They're up, they'll write notes to you. You can catch things faster because they're able to tell you symptoms. I don't know. What else do you want to know?
Everything, I guess. I know that there is always that fear that it's more work. I think because, you've seen patients come out of sedation. Like, we have patients that come from other facilities that have been sedated, and when they're coming off sedation, they are wild. And we also have delirium. When patients are in septic shock, they can get delirious. It's a lot of work. So I think when we mention that patients are not heavily sedated here, and hardly ever have any sedation, they imagine that they're crawling out of their skin the whole time, that they're trying to pull the ET tube. I think the instant mental imagery goes to their own experience when patients come off sedation. Mm-hmm. So what are your patients like? They get intubated, and then what happens?
We let them wake up from the medications that we use during intubation, just like, wake up naturally from that. And we just explain to them, it's a lot of teaching. It's a lot of explanation. You're not going to be able to talk. You're not going to be able to eat or drink anything. It's better for you if you are up, moving around. We're going to, you'll be able to write notes to us to communicate. For the first little bit, some people get really anxious. It's hard getting used to the tube, but after you get past that first little bit, it really does get easier and it gets better. We have patients that are watching TV. They smile, they laugh. They're able to visit with their families. And, they get up and walk around the unit. We have patients that listen to their music. We put music on our phones while we're walking them. We had one patient that was dancing while she was walking. So I think it's really good for the patients to be awake and participating in their care. I really think that it's a good thing, and it's good for families. Like, even when you have somebody that maybe is at the end of life, it gives them the opportunity to say goodbye and to have that chance to know that that person's there and talking to them, and they can say their last things that they need to say.
And you've seen that.
Mm-hmm. Yeah. Yeah.
And what does that mean to you as a nurse to provide that moment for your patients?
Yeah, you go home feeling like you've done something good for someone. I mean, even though the end result may be death, to know that you gave that family member that extra time, it's really important.
Yeah. And I know that when I was a travel nurse, I had a hard time really interacting with my patients that were comatose. I saw nurses that were really good at continuing to talk to them and interact with them as if they were talking back. But I had been so used to patients that I could see their eyes all the time, not just to check their pupils every once in a while, that it almost didn't feel real to me. And I wasn't very good at being invested in the patients. It wasn't that intimate. It just almost felt more mechanical because they were just comatose in the bed. But I watch you at the bedside, and you are so personable with them. What does it mean to you to be able to get to know your patients and to walk them through their critical illness? And some of these people are really, really sick, but they're still, like you said, telling you what they need and what's up. What does that mean to you?
I'm a people person. So for me, it's important for me to have relationships with people. So when I take care of somebody on a shift, it's important for me to get to know who they are, what they like, what they do. And you can't do that with somebody that isn't alert and participating. And you get to know their families, and then it's very exciting when the tube comes out, because you've worked really hard with them and you've gotten them up, and the walking, it pays off. Mm-hmm. And when the tube comes out, and they thank you, and it's good.
And they're able to they're human. I mean, they're not coming out of something. They're just always present. And then when the tube comes out, you finally hear their voices.
Mm-hmm. Yeah.
But it's not like you're getting to know a new person because you've already known that person.
Mm-hmm.
What about the logistics of it? I mean, are people restrained? Are they trying to pull at the tube? What about bed baths?
Sometimes people are restrained if they are anxious and they're trying to pull, but that's usually rare. A lot of times patients will ask me to restrain them before they go to sleep at night. They'll ask for me to put them on just loosely, mm-hmm. so that when in the middle of the night, they don't accidentally reach up and pull something out. So we will do that for them. But a lot of times they're fine just without it. They know the tube's important and they don't really mess with it. They do their own oral care. It's really easier taking care of them when they're able to help you. They get to the toilet. Our toilets are close. Mm-hmm. We have a toilet in the room, so it's not like it's far away. And sometimes the ventilator will reach. If it doesn't, we put them on portable ventilator to get them over to the toilet. So you're not cleaning up a mess in the bed.
Oh, I didn't think about that part. Because that would mean a lot to me to have the dignity of using the toilet and not just messing myself, mm-hmm. or even asking for a bedpan. Like having that sense of control in a really uncontrolled situation. When you don't have control, you can at least have that dignity and part of your humanity.
And when they're getting up and they're walking every day, they're not losing muscle. They don't need to go to rehab to build back that muscle. They're just doing it every day and they're not losing any of it.
And I think people really worry about the safety aspect of that. I know you've done a lot of data collection and studies on events that happen with our patients. I think people automatically assume that if they're not comatose, they're going to pull the tube out. If they get up to walk in the ventilator, we're going to lose the tube or they're going to fall. So from your experience and what you've been observing in our data, what's the reality of the safety?
So in 2019, we had 2 accidental extubations. One of those was our fault. It was during a code situation and the tube became dislodged. And the other was a patient in hyperbaric. So there was only 2 reported for the year of 2019.
But they weren't patients in delirious trying to pull their own tubes.
No.
They were exceptional situations.
Yeah.
And falls?
I don't know the exact number of falls. We follow the patients with wheelchairs. So when they're walking, we have a wheelchair close behind them. So if they look like their knees are going to buckle, we've got somewhere for them to sit. Every now and then somebody will go down to the floor. We help them safely to the floor, but it does not happen often. I imagine just like anywhere else, every once in a while somebody just falls.
But these aren't necessarily big hypoxic events. They're just anything can happen with walking. But are you afraid to walk patients?
I'm afraid not to.
Why?
I'm afraid not to walk them because I don't want them to not be able to walk again. I don't want them to get weak. I watched my uncles get weak and not be able to walk, and it was a lot of physical therapy and a lot of work that didn't have to happen if they would have been up and moving.
Right. And would they have been willing to?
Absolutely.
Now, do you feel like that would have changed their quality of life?
Yeah.
So that's where your trepidation comes from, having seen the recovery process.
Yeah. And it takes a long time, Well,
what about when patients don't want to walk? How often does that happen?
Well, sometimes they don't want to walk, and it's a lot of teaching. It's a lot of explaining to them, hey, this is why we want you to get up and walk. We tell them, okay, what time do you want to walk? We don't just ask, basically they don't really have a choice. I mean, they do, but it's like, do we let patients tell us no when they need antibiotics for sepsis? Yeah, if they say no, we explain to them, we teach them, we tell them why it's important. And at the end of the day, people want what's best for them. They want out of here.
Right.
They don't want to be in the ICU. So we don't get a lot of fighting. Every once in a while, you'll get somebody that really pushes back, but you just kind of learn how to work with them and make it a good, positive experience, and let them pick the time or let them have some sort of control.
Yeah. And I see patients keeping track of how far they've walked and excited about it. And they just today I walked in and this patient held up a 5. And I was like, well, what does that mean? And it was 5 laps. She wanted me to know that she walked 5 laps, which is 1,000 feet.
Right.
Right. Amazing. How often do you have patients asking to walk?
Oh, all the time. The patient you're talking about asked, she was ready to get up and walk. She asked when she could walk. And
she had been on the verge of ECMO, but continued to walk.
Right.
And she will never stop walking because of that.
Right.
And as a charge nurse, how do you foster this culture? How does everyone work together? Because you can't just walk a patient alone. So how do you help facilitate the teamwork?
It takes a group for sure. The charge nurses really help with activity. If you've got a nurse that's busy in their other room, somebody's not doing well or something, that when I'm a charge nurse, I think, okay, they've got this other patient. I need to make sure that they get their activities in. Other nurses in the unit know, hey, this person's been traveling for 3 hours with their other patient. I'll travel with a patient and I come back and my other patient's up in the chair. They've been walked. I don't ask. I don't even ask. They just, it's just the culture of the unit, and everybody just helps each other. But, you do have to get physical therapy. If they're vented, the respiratory therapist's schedule has to, it's a lot of correlation of schedules. And
I see that when the physical therapist walks onto the unit, it's almost like there's like a lineup, who's going to go first. Everyone's jumping and ready. I don't think the physical therapists are really waiting or trying to beg people to help them walk their patients.
No, they get bombarded. The nurses want to, me first.
Yeah, because I walk in and I go to assess patients in the morning, and they'll write, when am I walking? And I'm like, I'm not really involved in that, but I will ask. They're ready to go. They've been in bed all night, and they just want to get their bums out of bed.
Mm-hmm.
And we sometimes shower patients on the ventilator. What is that like? Is that just a huge hassle, or how does that happen?
So we put extension tubing on if it's appropriate. Respiratory therapy helps us. So that because the ventilator can't be in the shower.
Right.
And we have them in the shower, and it's just, the patients feel so good after getting their hair washed. Just, there's nothing like a shower. And doing normal everyday things, it really helps prevent delirium. So, we like to do normal activities, brush their teeth every day, if they can, shower, have them doing stuff on iPads,
We interviewed a Joanne, and she was an ARD survivor. She'd been on the ventilator for 17 days, and she talked about what it meant to her to be able to help shower herself, just the dignity factor. And I personally, when I was 14, I punctured my femoral artery, and I was bedridden for a few days. And then I distinctly remember that first shower, and it had only been a few days, but it was so heavenly to feel cool, like actual running water, to actually feel clean. I was tired of feeling sticky in the bed. I just can't imagine being on the ventilator for 17 days and having that lack of sensation of running water. It's one of my dreams to actually study that. How therapeutic, what does that do to morale, to raise the delirium, to take a real shower?
Mm-hmm.
And this patient, especially Joanne, was stuck on a PEEP of 12. Almost that whole time she had ARDS. And I know in some mobility protocols, patients are not allowed to even be dangled at the bedside. They can't even be held upright until their PEEP is less than 8. Now, this patient walked the whole time and took showers the whole time, and then went back to work like a month or two after her discharge. I just wonder how much her outcomes would have been so different, but her morale, even during the hospitalization, if she hadn't been moving, but hadn't been showered, hadn't been truly cleansed that whole time.
Yeah. When you don't move, your lungs don't get better. The human body is meant to be upright. Mm-hmm. We're meant to be up and moving. And so, when you're laying down, not doing anything, in my experience, I've seen, even my personal experience with my family member, I watched the ventilator settings go up. Every day I would go, and it would be higher oxygen, higher PEEP.
Which can still happen.
Which can still happen.
Probably had some ARDS or something really severe.
But they got also, infections, catheter-associated infections, VAP, things that you get from just laying on a ventilator for
you track our VAP rates, right? Our ventilator-associated pneumonias.
We haven't had one for I don't know how long.
I did see one last year, and it's because the patient was comatose. He had this big, huge mediastinal mass, and we had a steel-enforced ET tube, and we had to sedate him because they didn't want him moving at all. We were so afraid of losing that airway. So yeah, he was comatose, and he got a ventilator-associated pneumonia. And I think that only has happened when patients are not mobile. Mm-hmm. I think people really worry about patients coughing and gagging when they're walking on the ventilator. How much distress do you see in your patients, or does coughing worry you? Does it freak the patient out when they're coughing?
when they're coughing, they're getting stuff out of their lungs that needs to come out. When they're not coughing, it's sitting in there.
Yeah.
So, I would rather see somebody up moving and mobilizing those secretions. But if it's stressing them, they can always take a sitting break during ambulation. We let them sit, we let them recover, take them back to their room. If it's really bad, give them some suctioning. But they don't. The patient I walked today didn't cough at all while walking 1,000 feet.
Yeah. Yeah. And she has some of the worst lungs. And I don't see coughing that often either. I don't see gagging that often.
I don't know.
Joanne that we talked to, she had the worst gag reflex I've ever seen. And so she was in serious distress. That was really hard for her. Yet she still says she wouldn't have changed anything. She would have rather been gagging that whole time than have been sedated. But that's a big concern that people have. Is I put a picture on, or a video online, and one of the questions was, how is that patient not gagging and coughing? And it made me stop and think. I'm like, yeah, I mean, people do, but they usually don't.
Yeah.
But I think part of it is the delirium. When the clearer they are, the more they cope with it, the more they're used to it, the more they are just comfortable all around. Is that what you've seen?
Yeah. Yeah.
I'm trying to think, how else do we paint this picture? How has this affected your career and your fulfillment in your career?
Oh, I get a lot of enjoyment out of helping people get home, and not get home the way that they were before they came into the hospital.
Sorry, we're working.
Yeah. I don't know. I just think that I would want somebody to do that for me. I couldn't imagine coming into the ICU, being sedated, having delirium, and not being able to come back to my work. People have families and they need to have jobs, and a lot of these people that have delirium and they have long-term cognitive effects from being sedated, they can't go back to their jobs. And it puts a lot of strain on them, on their family members. It affects more than just the patient.
So you get to treat their lives as a whole and everyone involved in their lives.
Yeah, it's pretty incredible.
Yeah. Well, you have made such a great contribution to such a huge project and team and vision, and thanks for all that you do and for sharing that with us today. I hope that I hope we take this for face value. We're not exaggerating here. This is really how it can and should be in the ICU. Thanks so much, Brandy.
If you want to join in on the conversation, leave a voicemail at 801-784-0472